ahead and get started. Okay, thank you. So a very warm welcome to everyone joining us from various locations. And this ERG session is a very special one because it has been in the works for, I would say, almost a couple years. We have been talking about this topic of menopause. And finally, we are here today to cover this topic. So why the topic and why have we partnered with Wings today? Menopause is a topic that has been in discussion, and I have to say, I myself have recently gone through menopause, and it's not that easy. Speaking with many women across the world in CCL and in the community here in Singapore, I believe that we actually lose many good female leaders due to a lack of information, understanding, and support. And so that is one of the reasons why I believe it's an extremely important topic. Deepika Bajaj, who many of you remember was one of our women's ERG co-leads, had actually lined up a speaker on menopause. And as she transitioned out of CCL, we sort of didn't, move forward with that. And in fact, a couple of months ago, I was participating in an Empower Her AmCham event here in Singapore, and there were many highlights. It was a terrific event. One of the highlights was sitting next to Ting Mei, who is here today, and she's the executive director of Wings. She's an inspiring nonprofit leader here in Singapore, and Ting Mei is going to tell you more about Wings shortly. She introduced Wings that day, and she shared that Wings was helping organizations and companies with talks related to menopause. So bingo, I thought, here we are. Finally, we can have our talk on menopause and support a good cause at the same time. And Ting Mei brought us Professor Manju, who you will hear today, and she is a senior consultant endocrinologist and director of the Osteoporosis and Bone Metabolism Unit at Singapore General Hospital. She is also a clinical professor at Duke NUS Medical School here in Singapore, and she's going to talk about menopause without the noise, especially about bone health, one of her areas of expertise, but also longevity and what really matters. So I'm really looking forward to this. We encourage you to ask questions in the chat along the way, and we'll try to get to those after the sharing. And also, we encourage everyone to share some of their lived experience. We'll only be recording up until the time Professor Manju ends her presentation so that we can have a more open dialogue after that. Before I hand over to Ting Mei, I also want to recognize our women ERG co-leads. So if we can just go back for a moment to that slide. And we have, of course, Corey Atkins, who's here today. Heather Champion is here today. Manya, our co-lead for growth markets, APAC for the ERG, recently joined and has coordinated this session. And also Kanya Govind, our other co-lead here in growth markets, EMEA. So welcome to everyone, and Ting Mei, tell us a little bit more about Wings.
Okay, thanks, Alisa. It was really nice to have met you at the AmCham event. And I'm really thankful that CCL has decided to invite Wings for this year's talk. Just a little bit about Wings. We are actually a non-profit, and we were started or established in 2007 by Singapore's first orthopedic surgeon and NMP, Dr. Kanwaljit Soin. So she's very passionate about women and health, and we have been through the years supporting women through life transitions, and we hope to empower women with confidence and purpose through what we do, mainly predicated on learning, engaging, and volunteering. So for 2024 is just a report card there, just showing the number of programs that we conducted, the number of women or participants who went through our programs. And we encourage our women to volunteer their time and their talent in the community. So menopause is a topic that is close to our heart as well. And I'm very happy to have Prof Manju here to speak on behalf of Wings. She is a member of Wings, and we are certainly very privileged to have her here. So I'll hand this over to Prof Manju then.
Great. Thank you so much, Ting Mei. So now, Manya, you've stopped sharing, right? May I share?
Yes, please. Yes.
Okay. Oops. 1 second. Oops, what I can. 1 second, 1 second. Yeah, already zoomed to the. Okay, cool. So, well, I am told that there are colleagues from all over the world, CCL staff from all over the world. So it's really my privilege to be talking to all of you. And thank you very much, Elissa, and all the wonderful people at CCL who invited me for this talk. So, I would probably have to start off by saying good morning, good afternoon, good evening, and also in Singapore, where myself, Tingmei, and Elissa are based, it's already night. So a very good evening and night also to people who are joining us from Singapore. So, when I was first approached for this talk, I thought I was going to speak quietly about menopause and bone health, my safe little endocrinology territory. And then your organizers very enthusiastically informed me that apparently I was now expected to address menopause in the workplace, brain fog, sleep resilience, productivity, leadership, hormones, exercise, longevity, and possibly civilization itself. So here we are. But seriously, I think this conversation matters enormously because menopause sits at the intersection or interface of biology, work, identity, aging, and long-term health. And unfortunately, much of what women encounter is either silence or stigma or influence or nonsense or fear. So today, I would actually like to cut through the noise a little, and this is not going to be a detox your body with moon dust kind of talk, nor is it going to be everything is terrible and menopause destroys your life. The truth, as usual, is always more nuanced, isn't it? It's more interesting and much more hopeful because I think all of you deserve science tempered with understanding and acknowledgement, not hysteria. So, with that, I will kind of progress through the rest of my slides, which I've just put up just so that as a background. And like Tinmay introduced me, I have been, I direct the osteoporosis and bone metabolism unit at Singapore General Hospital. I'm an endocrinologist. I moved from the US 23 years ago to this little island nation, which I had no idea of, other than the fact that I, every year on my way to India to visit my parents, I used to stop off at Changi Airport. And I thought if the airport looks this good, the city must be, the country must be even better. And literally, that's how one day I've packed up my bags and moved to Singapore. And what was originally a move for a year or so, now it's been 23 years. So here I am talking to you all over from all over the world. So menopause has had quite the public relations journey over the centuries. So the ancient Greeks actually believed that menopause was the period when a woman's womb wandered all over the body, causing physical and emotional disturbances. And this kind of erroneous impression of what menopause is persisted all the way to the Victorian era, where menopause was medicalized, it was moralized and pathologized as female weakness or emotional instability. It was easy to blame everything on a woman's vapors and climacteric hysteria. And the word hysteria itself comes from the word hystra, which means womb. So that's kind of a little history for you. And if you were to actually look at the word meaning of menopause, it's derived from the Greek word menos, meaning month, and pausis, meaning cessation or stop. So essentially, menopause is cessation of monthly cycles. Literally, it's a stopping of monthly cycles and is a natural biological transition. It's not a disease. So if you were to fast forward several centuries, even up to about 15 years ago, menopause was a taboo topic, wasn't it? It was a hush-hush topic. Women whispered to each other about it at water fountains. It was not supposed to be asked of a doctor, etc. It was not a topic at all. And then now we have fast forward to the 2000s, where suddenly it's all over the place. It's on TikTok, it's on podcasts, it's on celebrity documentaries, it's on hormone influence. It's a main topic of hormone influencers. There are menopause retreats, there are certified menopause coaches. So we've gone from we never mention it. Two, menopause has become an actual industry. And somewhere in the middle is actual medicine, which is what I hope to kind of bring to you today, showing you evidence-based medicine tempered with, like I said, understanding and acknowledgement. So, what exactly is menopause? So, one important thing to know is that menopause is not an event that happens overnight. Okay, it actually, the symptoms can start back very early, in the early to mid 40s, often long before periods stop. And so you go through a period of what's called perimenopause, which is a transition phase, because this is where your cycles start becoming irregular, hormones fluctuate widely, and symptoms often start in. This can actually last 2 to 8 years, and this is why women, way before the actual period stop, they kind of complain of all these kind of weird fluctuating kind of symptoms. And women then say, I'm too young for this, but it's actually this perimenopausal period at that time. And then menopause, the actual menopause is defined, it's a clinical diagnosis. Menopause is a clinical diagnosis, not a biochemical diagnosis. It's not really, you cannot actually diagnose it based on blood tests. And it's defined as 12 consecutive months without menstruation. It's a single point in time confirmed retrospectively. You look back and say, oh, my last menstrual period was February 2025. So I've had, 12 months of amenorrhea, no menses, and that is when you're called menopausal. And then post-menopause is everything after that point, and health risks, especially for bone and cardiovascular health, accumulate during this phase. So the average age at menopause is across the world, if you were to look at, it's about 51 years, but it seems to happen much earlier in Asian populations. The average age is about 46 to 50 years. And in fact, in India, the average age of menopause is about 46. But early menopause is when menopause happens before the age of 44 years, and premature ovarian failure, premature ovarian insufficiency is when menopause happens before the age of 40 years. So what does happen hormonally? So the hormonal cascade, it's not simply about period stopping, right? Estrogen fluctuates widely during perimenopause before ultimately declining. Progesterone declines earlier, and even testosterone can decline. So the critical insight that you must take away from this is that estrogen receptors exist throughout the entire body. The receptors for estrogen, which is a female hormone, it exists throughout the entire body, in bone, in brain, in muscle, in blood vessels, in skin, in joints, in bladder and vaginal tissue. And this is why menopause can feel whole body, not just reproductive. And when menopause happens, because estrogen is this protective hormone in the bone, you get the loss of protection against bone resorption or bone loss. In the brain, this affects cognition and mood. In muscle, it can affect muscle strength, it can affect muscle metabolism, and of course, body composition is greatly affected. And vessels, in the blood vessels, your cardiovascular, your heart, and your vascular risk actually increases. And in the bladder, you can get genitourinary symptoms, which we'll talk about in a bit. And then in the skin and the joints, you can get collagen loss, you can get aching. I'm even told that you can even get like things like frozen shoulder and all that. The incidence starts rising at the time of menopause. So, but the most common symptoms, which all of us all know, and it is sometimes ridiculed. It's a subject of a lot of ridicule, and in even in the lay press and in cartoons and all that. But the most common symptom, which all of us immediately when you think about menopause, is that hot flashes, right? But symptoms can vary enormously. Some women, the lucky people, they barely notice menopause, and I must admit that probably I am one of them, but I have experienced menopause in a different way, because many, many years ago, when I was a young person, and I had this, I was actually put through what's called induced menopause for a short period of time. And that time I really experienced hot flashes. But in general, some women barely notice menopause. Others feel like their operating system changed overnight. Both are valid and both deserve acknowledgement. And like I was saying, vasomotor is the commonest symptom, and that is hot flashes. And it depends on which part of the world you live in. Some people call it hot flushes and some people call it hot flashes, but they're the same. And night sweats are the most recognized symptoms, affecting up to about 75% of women and varying in frequency and intensity. cognition and mood can be affected very much. You get brain fog, and it's a real entity, and I'll talk about that in a minute. Forgetfulness, mood changes. You feel kind of, you're just not capable, reduced resilience, fatigue, and these are all often underreported. And usually and frequently, they're misattributed to either stress or aging. And sleep, disrupted sleep, which can happen during menopause, is often driven by night sweats or hormonal changes. And that obviously, right, if your sleep is disturbed, that's going to affect your entire bodily system, and that creates a cascade that touches every other symptom category. And physical, like I said, you could have joint aches, weight redistribution, vaginal dryness, which again we'll talk about a little bit more, because these are all kind of taboo topics which are hardly brought up, right? Reduced libido and changes in skin and hair texture are all common, but the good news is that they're all addressable. So this big elephant in the room, which we hardly talk about, right? Sexual health in menopause. And so this is actually a recognized medical condition. So most of us now, at least with all this influence of TikTokers and hormone influencers and all that, we have at least started talking about menopause. We have started talking about hot flashes and all that, but we do not talk about the genitourinary syndrome of menopause, or GSM as we refer to it. Is actually a recognized medical condition caused by estrogen deficiency, caused by female hormone deficiency. And symptoms are extremely common. They're often progressive if untreated, and they're entirely treatable. And what happens is that declining female hormone levels, declining estrogen levels, it leads to thinning of the vaginal tissue. And this can actually cause a loss of elasticity and collagen. And this can actually result in a reduced blood flow to the vaginal area and lubrication. And you get a shift in vaginal microbiome and pH. And all this together increases discomfort, UTI risk, urinary tract infection risk, and pain with intimacy. But there are evidence-based treatments coming up for this too. And these symptoms are common, medical, and treatable. Women should never be told it's just aging, live with it. So now we come to my favorite organ, which is the skeleton, and the impact of menopause on bone health. And why does estrogen matter to the bone? So before menopause, estrogen maintains a careful balance between bone formation, the bone formation in our body, and this process of bone formation and bone resorption actually happens throughout our lives, right? And it's a very well-oiled machinery. The osteoblasts, or what I refer to as the bricklayers, they are laying new bone, and osteoclasts, the bone resorption cells, these are the demolishers. They work in perfect harmony throughout your life. But what happens is that after menopause, this balance shifts decisively towards resorption, and then this total mayhem and bone loss accelerates, particularly in the first 5 to 10 years after menopause. And in fact, some women, not all, okay, that's a very important distinction. Some women may lose up to 10 to 20% of bone mass in early postmenopause without feeling a single thing. And that is why osteoporosis is a silent disease. You may not even know it till you have a fracture. So osteoporosis produces no pain, no visible signs, and no warning until a fracture occurs, often from a fall. We call them fragility fractures. This could be inconsequential in a younger person or a person with healthy bones. And spine fractures can occur simply from lifting or bending in somebody who has osteoporosis, somebody who has got a violent burst of coughing, for instance. The bones are osteoporotic. You could have rib fractures and spine fractures. And hip fractures especially, all these fractures are quite serious. Hip fractures especially so because in older women, much, much older women, okay, they can carry a mortality risk of about 15 to 20% within the first 1 year. And survivors often experience permanent disability and loss of independence. So this is the end stage of a disease that was preventable decades earlier. And we all worry about breast cancer, which is rightly so. But if you had to think of it statistically speaking around the world, many women are more likely to suffer an osteoporotic fracture than breast cancer. So the question, because again, I'm talking to CCL employees, and I presume that most of you are desk-based administrative jobs, not just you, but in general, right? We are as globally, we are actually moving to a more sedentary lifestyle. And are we sitting ourselves into frailty is how I kind of refer to it, because hours of sedentary desk work provides zero mechanical loading to bone. Now, bone is a very funny little organ, okay? And bone, I would like to emphasize here at this point, bone is living tissue. It is not dead tissue as we kind of think of it as. So bone, what bone adapts is it adapts to load. But bone is a very lazy organ too. If the load disappears, bone quietly says, well, apparently we don't need this anymore. So hours of sedentary work, desk work providing zero mechanical loading to the bone, you start getting bone loss. Now, this can be exacerbated by stress and sleep loss, right? Chronic stress can elevate cortisol, which directly inhibits bone formation. Poor sleep compounds this by impairing recovery and hormonal balance. Irregular schedules and food. We are all rushing to something, right? We all want to get up there. We want to kind of know that we are in this rat race, and this irregular schedules, ultra processed food, alcohol, etc. They undermine nutrition, exercise habits, and then low sunlight, because indoor office life limits vitamin D synthesis. Already a challenge in Singapore and many, in Singapore, many Asian cities where sun avoidance is culturally common. None of us in Asia like to get tanned. So this is a real problem, and compounded by in countries where there is significant amount of pollution and all that, even in sunny countries, you can get low vitamin D synthesis. So I would like to correct a couple of bone myths. One of them is that if I drink enough milk, I won't get osteoporosis. We'll talk about that in a little bit. I will leave that for now. But the other common myth is that only thin women get osteoporosis. That's false, because while low body weight is a risk factor, women of all body compositions can develop osteoporosis because there are several other factors like metabolic factors, ethnicity. Asians and Caucasians, and by Asians, I mean East Asians and Caucasian women, just by the nature of their ethnicity, are at higher risk of osteoporosis. Family history, if your mother especially, or your parent or your mother has had a hip fracture, osteoporosis, you're at higher risk. Certain medications, which unfortunately they are important to take, like steroids or thyroid hormone medications, which are used to treat underactive thyroid, if they're taken in excess, these can all cause bone loss. And the other myth is that I will know if my bones are weak. You won't. Problem is, like I said, osteoporosis is an entirely asymptomatic disease until the fracture happens. There's no pain, no stiffness, no detectable sign, okay? And this is precisely why proactive screening exists. So I just have a couple more slides on bone, but people ask me all the time, I just came through menopause, when should I get bone density testing? So this thing called dual energy X-ray absorption, it's a big word, but it's a short form is DEXA. It's essentially bone mineral density testing of the hip and the spine. It's a gold standard for assessing bone mineral density, okay? And it's not like every single postmenopausal woman should run out and go get a bone density scan. But if they have specific risk factors, that should prompt earlier assessment. If you had a fragility fracture, and by a fragility fracture, we define a fragility fracture as fracture happening from a fall from standing height or less, okay? That warrants immediate bone density assessment and treatment consideration. Early menopause, if you had menopause before the age of, like I said, 44, that's considered early menopause, and especially if your period stopped before you were 40, that's premature ovarian insufficiency. That definitely is an indication for bone mineral density testing. If you're on high doses of steroids for some reason, maybe it is for asthma, maybe it's for rheumatoid arthritis, that puts you at high risk. And other significant risk factors like family history of hip fracture, very low BMI, very low body weight, if you smoke, high alcohol intake, and certain medications, like I said, all elevate fracture probability and justify earlier screening. So I'm leaving the bone aside. I promise I'm not going to be boring you with too much about bone. Let's come back to menopause as such, and what are normal menopausal symptoms versus when should you seek help, right? So probably, again, like I said, there's a wide variation of symptoms. Some women breeze through menopause, while others may have some kind of symptoms. whereas others might be crippled by it, right? So within normal is when occasional hot flushes or flashes of mild to moderate intensity after a period stopped, or during the perimenopausal period, mild transient sleep changes, or if you have irregular cycles during perimenopause, that's expected. I mean, so during perimenopause, when estrogen levels start fluctuating, then you will get these irregular cycles. Transient mood variability and irritability. You can't, I mean, much as I would like to, you can't blame every time that you're in a bad mood. Oh, that's because of menopause, right? So those are all okay. But definitely a woman should be seeking medical attention if even after the period stop, you can sometimes get these severe abnormal uterine bleeding, or in the perimenopausal period, if you get severe abnormal uterine bleeding, profound depression or anxiety, disabling insomnia, the person can't sleep at all and is tossing and turning through the night, or severe cognitive symptoms, or like I said, fractures if they happen. And of course, menopause before age of 40, it's a must that you seek medical attention. So just one word, slide on menopause in the workplace, and I will leave it for further discussion during the Q&A session. But obviously, menopause is, when you're going through menopause and you're a working woman, this is going to be compounded by the stress at work. You get sleep fragmentation. Even, you know that even moderate sleep deprivation significantly impairs executive function. It can affect working memory. It can dysregulate your emotions, and in bad cases, decision-making quality, right? And vasomotor symptoms. Hot flushes during meetings are not a minor inconvenience. They interrupt concentration, disrupt composure, and can trigger anxiety in professional settings. The woman can start thinking, I'm not capable enough. And when actually, poor thing, she's actually literally going up in smoke, right, from the hot flashes. So these are very common, and this is something that we definitely should address. And let's just talk about brain fog. We all kind of, bandy this word around saying, oh, brain fog, right? Is it real? Yes, it is well documented. And women frequently report word finding difficulty. Women in menopause, menopausal women frequently report word finding difficulty, reduced concentration, forgetfulness, and mental fatigue during perimenopause and early postmenopause. These complaints are real, they are measurable and physiologically explainable. Now, the important reassurance is that this brain fog is not dementia, okay? And how do you distinguish between menopause-related cognitive changes and dementia? Because menopause-related cognitive changes typically fluctuate. It's not like every day you can't remember a single thing, right? They typically fluctuate and improve over time. And so you just have to give it a little time. It do improve over time, and it's strongly linked to sleep disruption and elevated stress, both of which are thankfully modifiable factors. Unlike dementia, which is progressive, it does not fluctuate, and you can't just sleep it off and think, oh, tomorrow morning I'm going to wake up and I'm going to start remembering and think. No, dementia does not improve with sleep. Whereas, like I said, menopause brain fog fluctuates day to day. It's often tied to poor sleep and responds to lifestyle changes. And an appropriate candidate's actually hormone therapy. But women who are concerned about cognitive decline, they deserve validation and not dismissal. And the appropriate response is assessment and not reassurance without inquiry. So now let's talk about nutrition exercise. So this is a little kind of feature. This was featured in the Straight Sims many years ago, and I kind of took it from there. And fully life are that simple, right? Drink your milk, eat your kailan, and lift weights. This will keep osteoporosis at bay. Unfortunately, of course, life is not as simple as this always. But let's talk about exercise in menopause. What actually helps? The best evidence is resistance plus impact plus balance exercise. Okay, so you combine brisk walking, stair climbing is wonderful, along with resistance bands and free weights. Dancing and racket sports like tennis are really good. Hopping and jumping where appropriate. There are studies which show that really can be have a good effect on your bones. And yoga, I am becoming a slowly a yoga convert. But I know that yoga alone is not going to actually, we looked at this massive, we did this massive systematic review and meta-analysis. And what we found was that yoga does improve balance, and it may prevent falls, and it may improve muscle strength. But directly on bones, it may not really have much effect on its own. But if you combine it with resistance work, that may be useful, especially for the bones. And so these kind of exercises, they create both the mechanical loading and muscle pull that bones need to maintain density and strength, right? But on their own, these kind of exercises on the right side, stretching or flexibility training, because a lot of my patients can say, oh, I stretch every day, but that's not enough. And gentle yoga without this resistance component is probably not good, great for the bones. It's good for your overall feeling, good feeling, but probably not good for your bones. Swimming, because it's excellent for cardiovascular health, but it really has a low impact on bone strength, because obviously the water takes your body weight, right? So the key principle is that bone likes impact, and muscle is bone's best friend. The more muscle mass a woman maintains, the better her bone protection and her metabolic health. What about nutrition? And this is in general for menopause, not just for bone, but adequate protein is essential. And nowadays, I know everyone is on this high protein kind of loading diets, but definitely in older adults, for instance, you need about 1 to 1.2 gram per kilogram body weight of protein. And in a very actively exercising person, you probably need 1 to 2 gram per kilogram of body weight. Calcium, you do need 1,000 to 1,200 milligram per day. And I always say, take it from best source of calcium is from diet. A supplement only if needed, because people think that's one of the big myths that I'm going to be busting here, that people think that, oh, I take calcium supplements, why did I still get osteoporosis? Calcium on its own, definitely it is important bone health, but it's not going to prevent osteoporosis on its own. Neither is vitamin D on its own, but definitely on its own. Definitely, if you have vitamin D deficiency, you must treat it. But in general, get sunlight exposure, and we can talk in Q&A about what is a good time for sun exposure, etc. And in countries where there's limited sun exposure due to weather, I mean, you can't tell a person, oh, you should go out in the sun every day from 10 to 3 or 10 a.m. to 3 p.m. When you are living in the frozen northern parts of the world, like Iceland or something, where you hardly see the sun, right? So in countries where there's limited sun exposure due to weather or pollution, which is a big factor, you might need supplementation. Fruits and vegetables take a lot if you don't have conditions like diabetes and all that, because they're such wonderful sources of fiber and micronutrients, and in addition, they're anti-inflammatory. And avoid smoking. And I initially, my slides used to have moderate alcohol, but more and more, much as all of us like a little glass of wine, there's more and more data showing that even one glass of wine or any kind of liquor is probably not that great. So I'm going to bust a couple of myths now, okay? So some people, collagen powders alone will save my bones, but no, bone requires load, it requires hormonal support and full nutrition, not just one supplement. Menopause permanently destroys metabolism. And again, we always kind of say, oh, I put on weight and that's because my menopause happened and my metabolism slowed down, is permanently gone. No, weight redistribution is real. You do get this, what we call abdominal fat and all that during menopause, but metabolism is modifiable with muscle mass and exercise. And the biggest myth of them all, that, oh, I take a lot of dairy products and all that, and I still got osteoporosis. Like I said, calcium is necessary, but is not protective in isolation. Bone density depends on mechanical loading. It depends on vitamin D status. It depends on a lot on your genetics, unfortunately, protein intake, hormonal milieu, etc. Okay, so we come to this controversial topic of hormone replacement therapy, which is actually the most confusing topic in menopause. The thing is that it's well established that hormone replacement therapy, or HRT as we doctors like to call it, has got well established benefits. It's the most effective treatment for hot flushes and night sweats, can improve sleep quality. It can treat what we call genitourinary syndrome of menopause. Remember earlier I said you get these UTIs, vaginal dryness, etc. It has been shown to very clearly prevent and reduce bone loss and reduce fracture risk too. And it may benefit cardiovascular health when started early. But risks, there are risks. Okay, so I like to talk of it as hormone replacement therapy is not a poison, nor is it the asterisk of no, it's not the elixir of life. There are risks. but the risks depend upon age and years since menopause. It depends on the formulation of the type of hormone replacement therapy used. Is it estrogen alone or is it combined with progesterone? It depends on the route. Is it oral versus transdermal, which is on the skin, duration of use, and depends on individual risk factors, whether you have pre-existing cancer, whether you're at high risk for blood clotting, whether you have a cardiovascular kind of history, right? So I'm going to kind of stop here for just a second to kind of bring you up to speed on this, what we call the WHI story. So WHI stands for Women's Health Initiative. Something big happened in the world in 2002, right? So the Women's Health Initiative, which was this large study, it published results linking hormone replacement therapy to increased risk of breast cancer, stroke, blood clots, and coronary artery disease. And the headlines were quite alarming. In literally overnight, hormone replacement therapy prescriptions collapsed worldwide, and many women and clinicians never recovered their confidence in it. So this was in 2002, and now we're in 2026. Even 24 years later, a lot of clinicians have never recovered their confidence in it, and women also become scared stiff. But actually, the story is a lot more nuanced because later reanalysis revealed a critical context to it. The average age of participants in the WHO trial was approximately 63 years, more than a decade past menopause. So these people in the WHO trial who suffered from, who had a higher risk of breast cancer, stroke, blood clots, and coronary disease and all that, probably should not have been started on hormone replacement therapy in the first place because they were more than 10 years post-menopause. Many of these participants in the study had pre-existing cardiovascular risk. And so, as I said earlier, the risks differed substantially based on timing, patient profile, and formulation. So with the current consensus, thankfully, we're moving away from this, oh my God, hormone replacement therapy should not be given to any woman in their menopause. We moved away from that to for a properly selected, younger, symptomatic women. This woman is poor thing. She's suffering from hot flashes. She's going bonkers because, I mean, she's got brain fog, all these, she's got vaginal dryness. She's having all these symptoms. And you're still saying, no, 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 I will not give you HRT. That's no longer recommended because for a properly selected, younger, symptomatic women who are initiated near the time of menopause. So let's say I became menopausal at 50. Just giving kind of a fictitious example. So, and I start on hormone replacement therapy at the age of 50 because I'm having hot flashes and all that, then actually that is good and it'll help me a lot. And you do not continue it for life. You would probably kind of give it for another 10 years or so. Okay. So so if it started at the time of menopause, the benefit risk profile, you always, as in life, you're balancing the risk versus benefits, right? The benefit risk profile of HRT is often favorable. And this is now supported by many guidelines, including the International Menopause Society 2025 guidelines, right? And so the modern individualized approach to hormone replacement therapy, and again, I should pause here for a second and just tell you that obviously I'm speaking to the lay public, and I am not going to give, even in the Q&A, please don't expect me to give you individual answers to individual questions like, oh, what dose should I be on kind of thing, because that is something that you should have to discuss with your doctor. But the modern individualized approach to hormone replacement therapy is number one, it should be an individualized risk assessment. And your prescription, a doctor's prescription of hormone replacement therapy should not be driven by population level fear. It should be driven by the doctor and you have a conversation. And if you have a personal family history of breast cancer or cardiovascular disease or clotting disorders, etc., then obviously you're not a candidate for hormone replacement therapy. Like I said, timing matters. The window of opportunity, what we call the window of opportunity, initiating hormone replacement therapy within 10 years of menopause or before the age of 60 carries the most favorable benefit risk profile for most women. And the formulation route, the type, okay, transdermal, which is applied in the skin or intravaginal kind of estrogen, carries lower thrombotic risk than oral. Thrombotic meaning blood clot risk, okay? And the WHI trial where they combined hormone replacement therapy, where they were using progesterone, that was a kind of different progesterone, right? Nowadays, we have this micronized progesterone appears safer than older synthetic progestogens. So these choices matter. And like I said, a shared decision making. Hormone replacement therapy is not mandatory, but at the same time, fear-based blanket avoidance is also outdated. The goal should be an informed, individualized conversation, not a universal prescription or prohibition for that matter. What about women who cannot or don't want HRT? So people who cannot have it because of like all these risk factors that I said, what about them? Or some people may say, I really do not want to be on any hormones, right? So lifestyle and they're still suffering from symptoms. There is help because exercise and sleep optimization can help. Cognitive behavioral therapy, or CBT, has actually been shown to be useful for hot flushes and insomnia. Dietary adjustment and stress management all carry meaningful evidence. And there are non-hormonal pharmacological options for these things like hot flashes and all that. These medications called SSRIs and or SNRIs. I'm obviously not going to kind of go into them in detail. And there are even newer, what we call NK3 receptor antagonists or fezolinetant and all that. These all offer an effective non-hormonal therapy. And then local therapy, right? Because obviously somebody who's having vaginal dryness, having really tough time during periods of intimacy and all that, you start off with vaginal moisturizers and lubricants and low-dose vaginal estrogen, which is minimal systemic absorption, which means that it is not absorbed into the blood. They can be used to address genitourinary symptoms without systemic hormonal risk. And then practical workday adjustments, which I'm sure we can talk about later too, but I always tell people, look, these daily habits compound over time. Movement breaks, right? Now, I walk around all over the hospital, right? Most of us doctors, but there are clinic-based doctors, right, who just sit in their chair from morning till evening. But you can take short, what I call exercise snacks, right? Movement breaks, standing, walking, stair climbing throughout the day. Brief loading like this, these loading bouts actually matter more than most people realize. Sleep hygiene, you keep a consistent schedule, keep your sleeping environment cool, limiting screens and alcohol in the evening, and a very practical kind of thing that I tell people is a layered clothing for people who go into work. I mean, it's freezing outside, but then you go inside and and you start having these hot flashes. So layered clothing, a simple practical strategy for managing hot flashes in professional settings without embarrassment. And like I said, sunlight exposure, even 15 to 20 minutes outdoors at midday supports vitamin D synthesis and what we call circadian regulation, which means that your sleep-wake cycles, right? And this is what I meant. Exercise snacking, right? This is very practical. It's really common sense. A brisk walk to a meeting, taking stairs instead of taking the lift, these all accumulate meaningful skeletal and musculoskeletal benefit across a working week. And it's not perfection is not the goal, folks. Consistency is. And again, I can repeat ad nauseum, avoid excessive caffeine, avoid alcohol, prolonged unbroken sitting, etc. And what should women have reached pretty much the end of my talk? What should women ignore? Okay. We all should safely ignore detox programs. The liver does not need a cleanse. So this whole thing about detoxing and all that, it is really, it's a myth. Expensive multi-panel hormone testing. Somebody is going to make money off you. I mean, if they'll offer all this multi-panel hormone testing, which is marketed online and otherwise, I would avoid that. Miracle supplement stacks with no clinical trial evidence. Adrenal fatigue is another term which is commonly bandied about, that it's not a recognized clinical diagnosis. And influencer medicine. Everyone is a doctor these days, right? On Facebook and Instagram and TikTok and all that, they can come across as very compelling, but they're largely unregulated. It's often more profitable for the influencer than for you. But you invest your attention here instead. So you say no thanks to all this, miracle pills and detox tea and adrenal fatigue and all that, but invest attention here instead, which is sleep, the single highest leverage modifiable factor, resistance exercises, non-negotiable for bone muscle, cardiovascular risk management, which, avoid smoking and all those kind of things, which can increase your cardiovascular risk, and evidence-based care from clinicians familiar with current menopause medicine. And if you have these risk factors, you go for a bone density assessment. One slide on menopause and longevity. Obviously, the goal is not simply to live longer, right? It's to remain functional, independent, mentally sharp. we're living, all of us are living longer and longer, right? And so, in fact, in current times, women today may live 30 to 40% of their total lifespan after menopause. That's 3 to 4 decades enough time for preventive action taken now. I'm assuming that most of us are in the perimenopausal or yeah, there are a lot of young people too, I know, in the audience. But so what you do when you invest in your bone and muscle bank now is going to pay off later. It is not the beginning. Menopause is not the beginning of decline. It's a biological transition that managed intelligently need not define your health trajectory. So the final message, folks, is that menopause is a natural biological phase. It's not a failure. Bone health is important. You monitor and protect your bones proactively. Small steps today is going to result in strong bones tomorrow. Quality sleep influences all menopausal symptoms. Nutrition, nourish your body well. It's the best investment. And exercise, strengthen muscle, preserve function, and as well as bone. So with that, I would like to leave you with this take-home kind of slide that women do not become less valuable after menopause. They become older, often wise. I won't say that all of us become wise, but the thing is that we are frequently overcommitted and occasionally sleep deprived. But we are very valuable pre or post menopause. I think all of us are equally valuable. And these are some of the key references that if you want, you can kind of go back and look up. These are all the big the guidelines that I brought up, as well as the Women's Health Initiative trial. It's interesting reading that, right? And the subsequent reanalysis. So with that, I will stop my presentation as such, and I'm very happy to answer any questions.
Wow, that's so much there for us, Manju. Really amazing, informative, so valuable, the perfect recipe. To not lose any time for the questions, I want to get us into the photo right away. So if we could ask everybody to come off to come onto the video, in fact, if you can come onto your video, and who is going to take the photo? So they can give us a signal. So if everyone just kind of position yourself to get ready for the photo. Corey, are you going to be taking the photo? Or is it somebody else?
I think the Manya said you can.
I can. I just don't see everyone on my screen.
I think there is some kind of
put it in gallery, and then we can
Okay.
just
Manya,
give
why don't you do it then, Manya?
Okay, give us a bit of a 3, 2, 1.
might have to take it twice because we have many people and they don't fit in one screen. So we'll do it twice.
Okay.
Yeah. Give me a moment. Yeah. Just a second. Oh, my laptop is glitching. Can you just give me a moment? I'm so sorry.
Here, I can do it.
Yeah,
While
thank you.
she's
so
doing-
I'll have to do two, one for each slide, but ready, everybody, smile. Okay, I got the first one. And then, oh, everybody smile again. Okay, got him.
Okay.
Wonderful. Thank you so much.
Send that out after. Okay, so please feel free to come off mute with any questions that you have.
And also if we can stop the recording.
Oh yeah,